Okay, good morning. So we'll get started. Welcome to Neuroscience. This is the last time, actually, we'll teach the course this way. For the students coming in next year, we'll combine neuroscience with psychiatry. But this course now, basically, in the first year, we'll be going over all the normal neuroanatomy, neurophysiology. Our second year course is more of the clinical applications of that. And so I just want to spend a little bit of time giving you a bird's eye view of where we'll be going in this course. And so first, introductory material. This is what we'll be doing here in the first couple of weeks. And so our lecture, it's kind of strange today to have a lecture at 8 and then again at 11, but we'll be going over gross brain, showing you the names of the major parts and structures. And then tomorrow we'll go over vasculature of the brain, CSF, and meninges. And then we have our first of 3 brain dissection labs tomorrow afternoon to really reinforce everything that we're telling you here in the first few lectures. And then we'll have 5 lectures on the neurology examination, which is really not, here's how you do the exam, but we'll be going through the examination as a means of illustrating pathways. And how, if you take a safety pin and you tap the patient on the foot and they feel that it's sharp, well, how does that get from the foot to the brain? And so we'll use the neuroexam kind of as a means of going over all of the neuroanatomy and the pathways. Okay, and then there's just a lot of background things. The neurophysiology course, I gave you 3 lectures there, is introductory material about neurocytology, neuroembryology, and some things done in anatomy is somewhat of an introductory foundation for this course. Okay, so after we're through that, we'll do what is, we'll call a regional approach. And we will start this year really with the peripheral nervous system, and we'll work our way up to the brain. So we'll talk about peripheral nerves, the plexus, roots, spinal cord, then we'll go up through the brain stem and up through the brain. Okay, we have some labs that will go along with that. And then here at the end of this course, we'll try to tie things together in terms of systems. So motor systems, for example, you need to know how the brain is involved, how the brain stem is involved, how the spinal cord is involved, how the peripheral nerves are involved. It's kind of tying everything together. And so we'll go through all of these systems here in this course. And then in the second year neuroscience course, this is where this is kind of, I think, the more fun and exciting part, because we talk about patients and we show a lot of videos and we talk about neurologic conditions. But it's maybe worthwhile just for you to see that these are, the whole point of this course is that you become really comfortable with these different neurologic conditions. And a lot of these are common. You don't need to be a neurologist to see these conditions. So headache is certainly one of the most common things that you will see as a physician, and this is the course where we'll learn about that. One of the most common reasons to see a physician and even to go to the emergency room is for dizziness. And so that's a neurologic kind of a thing. And so you need to know the anatomy of quite a bit to understand the complaint, I am dizzy. Okay, and so stroke, dementia, multiple sclerosis, a lot of very common things that you will need to know as a physician. The foundation here is the neuroscience course. So one thing that I've worked very hard to structure the course is around the concept of planned redundancy. Okay, so we want to, the key things I want to be able to tell you many times. Okay, and so, and I can tell you with confidently, because the second year students just finished the neuroscience course, that everything I'm going to tell you here today and tomorrow, we will go over so many times, by next December, that these basic things will not be hard for you to remember, because we cover them so many times. Okay, so we'll try to do that very carefully. And also for me, I'm a neurologist, and so just practically I want you to be able to see patients with neurologic things and to feel comfortable. And so there's definitely an emphasis on clinical application. So anytime, even in these first few lectures where it's mainly just the normal parts and the pathways, if I say something clinically about it, well, that's important. I try to ask questions clinically as much as possible. Okay, we want to avoid a well-described condition called neurophobia. There's actually, if you search, there's quite a bit in the literature. Ralph Josephowitz, who was my mentor in neurology education more than 20 years ago, has written several articles about neurophobia, a chronic disease among medical students. And the problem is basically learning the neuroanatomy in a way that is disjointed from anything that is clinical. And so what happens is students get into third year clerkship, or you're a physician and you see neurology patients, and just all of neurology is scary. And let's just order a brain scan, because we can never figure this out, by doing an exam or a history. So we'll work hard to avoid neurophobia. Okay, realistically, I realize very few students read this textbook, okay, because our handouts are pretty detailed, but it is still an excellent textbook by Blumenfeld, Neuroanatomy Through Clinical Cases. It's actually one you can use in the third year clerkship as well. So if you're interested in having another resource, but I don't ask specific questions from that. But it does have some nice pictures, and if there's something that isn't making sense in the course, that might be something worthwhile looking at. You really do need to have an atlas for this course, because in our 3 brain dissection labs, and when we go through brainstem and spinal cord sections, you need to have something you can look at and spend some time being able to identify things in an atlas. So we have a lot of resources on Canvas. Already I must have at least 20 or so little patient video clips on there to illustrate different things, and so you'll want to spend some time seeing what's available there. I also, for the last year or so, have been putting all of my lectures on YouTube, only because, for example, we just had students starting the third year clerkship today. I just gave them an orientation lecture. They want to go back and listen to some of the first and second year lectures, and I don't know why, but it's impossible to give them access to Canvas for first and second year. So it's all there on YouTube. But if you want to, I have all the lectures from a year ago that are there. You can, if you want to pre-listen or whatever, and I'll put them up as we go along, updated here for this course. So there's a playlist there. You can, one thing that would be really important before tomorrow, I video recorded a brain dissection from last year, and I think it would be very helpful for you to watch that in preparation. It's not very long for our brain dissection lab tomorrow. And then there's a playlist called Neuroanatomy, and that is basically all of this course, the first year neuroscience course. Okay, and when we start the second year course, I'll give you a board review handout, which is really all of first and second year neuroscience that I think you need to know for step 1 boards. But I won't give that to you now, because it's we haven't covered anything yet of that. All right, so in these first 2 lectures here, again, we're just going to learn the parts, the nomenclature, plumbing, try to make it a little interesting by occasionally making some clinical applications. But for the most part, it's just a lot of names that we're just going to get through fairly quickly. So this may seem a bit overwhelming, but I just want to reassure you we will cover this in multiple cycles. And I think our 3 brain dissection labs will really help as well. So the function and clinical significance will be at a very superficial level here at the beginning. So maybe as kind of a framework, we can use neuroembryology to just illustrate different levels of brain neuroanatomy. So we have the brain, which is divided into the cerebrum and the brainstem. The prosencephalon, embryologically, is equivalent to the cerebrum. Okay, and prosencephalon we divide into 2 areas, telencephalic structures. The telencephalon is equivalent with the cerebral hemispheres, and the diencephalon, which is anything, as you can see here, with the name thalamus in it. So telencephalic structures are the cortex, white matter, basal ganglia, limbic system, and olfactory system. This whole lecture today will be almost only on the cortex, and we may get just a little bit into white matter. So that's all we're going to do today. Okay? We can see that embryologically each level here is associated with a cavity. So for the telencephalic structures, wherever we're seeing cortex, white matter, basal ganglia, and so on, we will see parts of the lateral ventricles. Okay, whereas with the diencephalon, remember anything with the name thalamus in it, there we're going to see the third ventricle. Okay, the brainstem is the mesencephalon and the rhombencephalon. The mesencephalon is equivalent to the midbrain. Okay, and when we look at the midbrain, we'll see the cerebral aqueduct, another cavity. The rhombencephalon divides into a metencephalon and myelencephalon. The metencephalon is the pons and the cerebellum. The myelencephalon is the medulla. Okay, and for all of that, for all of the rhombencephalon, it's associated with the fourth ventricle. Okay, and then we have the spinal cord, okay, with the central canal. So just as a bird's eye view, the telencephalon are the cerebral hemispheres. Okay, so all of the telencephalic structures here are in the hemispheres. Diencephalon is in this area in green, and then we have the mesencephalon, which is equivalent again with the midbrain. Okay, the metencephalon, which is the pons and the cerebellum, and the myelencephalon here, which is the medulla. Okay, so clinically though, when we talk about the brainstem, we mean the midbrain, pons, and medulla. So from here on out, anytime I say midbrain or brainstem, it's midbrain, pons, and medulla. Even though here embryologically you can see the metencephalon is the pons and the cerebellum. Okay, so embryologically that's true, but clinically the brainstem is the midbrain, the pons, and the medulla, not the cerebellum. All right, so let's start with telencephalic structures. And initially here, let's start with the cortex. Okay, so remember, we'll look for parts of the lateral ventricle here as we do this. And tomorrow we'll have a whole lecture on CSF, and we'll talk about how cerebral spinal fluid flows in these different cavities. Okay, so what is the cortex? I'm sorry, would someone be able just to maybe turn the front lights down a little bit? Sorry to put you on the spot there. I should have. Perfect. That helps. So the cortex is the thin ribbon of neurons around the surface of the brain. Okay, and so we can see this here all the way around, about 3 to 5 millimeters. Right? So all of this around here is the cerebral cortex. Okay? And we will look at this and we'll talk about how to divide the cortex into different areas by referring to a gyrus, which is a fold, and a sulcus, which is a groove in between the folds. And if we have a really deep sulcus, we'll call it a fissure. Okay, so for example, this would be a gyrus. Okay, the intervening groove right here would be a sulcus. Okay, here is a very deep groove right here, so we call this a fissure. And if we look on the top of the brain, we have a very deep area right here, so this is a fissure, the interhemispheric fissure. Okay. And when you look at the brain in our lab tomorrow, you can see, well, how can I know exactly where things are? It just seems like it's all, hard to figure out. So we'll need to have some landmarks here to help you identify the different lobes and so on of the brain. So the cortex is mainly buried, because of all of these folds, 2/3 of it is actually buried deep within the sulci. Okay, and so we will use these different gyri, sulci, and fissures to divide the brain into a frontal, parietal, temporal, and occipital lobe. Okay, so it's a big picture. Okay, we have the frontal lobe, temporal lobe, parietal lobe, and the occipital lobe back here. Okay, just as an interesting thing here, how many neurons in the brain? Maybe 5 or 6 years ago, someone actually did a pretty detailed study and estimated that there are 86 billion neurons and about equal number of non-neuronal cells. Some think there are more non-neuronal cells than there are neurons. And we, not a bad correlation here with the number of stars in the Milky Way. So here's a slice deeper down in the brain, because we can see there are some deeply located neurons as well, and I'll tell you what those are here at 11 o'clock this morning. Okay, but clinically it is important. We will talk all the time when you do the third year neurology clerkship. Patient has a problem, and we'll say, well, is it a cortical or a subcortical problem? And so cortical would mean, well, we've got a problem with the cortical neurons. Alzheimer's disease would be kind of a classic cortical condition where the cortical neurons degenerate and patients have dementia. Subcortical would refer to deeper conditions where the problem is deeper down. So for example, this is white matter here. It's deeper than the cortex. So this is a subcortical structure. So multiple sclerosis is a condition we'll talk about quite a bit, where we have demyelination here of this white matter. And so that would be an example of a subcortical condition. Okay? And you'll understand why later it's important that we make that distinction. We're going to work up a cortical condition a lot differently than we're going to work up and treat a subcortical condition. Okay, I should have mentioned that a couple of days ago I uploaded a handout that had some of the arrows were mislabeled. So if you downloaded that on Saturday or so, make sure you download the more updated one from yesterday, because I think these arrows got moved. But here's the structures here to know on the lateral surface of the frontal lobe. First of all, what are some landmarks? And I'll be using a lot of just cartoon drawings because it's easier, and then we'll use the lab to look at real brains and try to figure this out. So a few landmarks here for the frontal lobe. First of all, we have this sylvian or lateral fissure right here. And so this is the floor of the frontal lobe right here. So everything above that right here is frontal lobe. And our posterior landmark here for the frontal lobe is this central sulcus right here. Okay, so all of this is frontal lobe. Okay, now the gyrus that is just anterior to the central sulcus right here is called the precentral gyrus. And this is a very important gyrus because this is motor cortex. When you initiate movement, that activity originates here largely from the precentral gyrus. And in a little bit I'll tell you exactly where the face and the arm and the leg motor fibers are located here on this precentral gyrus. Okay, the frontal lobe here has a superior, a middle, and an inferior frontal gyrus. Okay, and so just to tell you a couple of clinically relevant things, here on the middle frontal gyrus we have the frontal eye fields, frequently called the saccadic gaze center. I listed both of those in your handouts. It's one thing that's often difficult about neuroscience. Many of these areas have two names, sometimes even three names. So whenever there's something that is frequently both are used, I'll tell you. So frontal eye fields or saccadic gaze center. You should be familiar with both of those terms. And we will talk about this pathway that originates from here quite a bit. It's very important for eye movements. Okay, so when we explain later how your eyes move from side to side, we will start by talking about the frontal eye fields or the saccadic gaze center. But for now, you need to know that's on the middle frontal gyrus. On the inferior frontal gyrus, we have an area here labeled B, which is Broca's area. And this is an important area of language function. It's usually on the left hemisphere. Okay, and this is for speech output. Okay, so when you're talking, Broca's area is where the words are coming from, so to speak. Okay, so we'll explain quite a bit of detail here in the neurology examination lectures how language works, but this is speech output. Now you can see when we actually look at a real brain, it can be hard to determine. So is this the central sulcus? Is this the central sulcus? And that's what the lab is for. And I'm going to tell you, because you really need to hold the brain and be able to tilt it around to figure that out. Okay, so for now, we're just going to use an easy cartoon drawing, but just remember, it isn't that easy actually to determine frequently where the central sulcus is. Okay, let's say a couple of other things clinically about the frontal lobe. Okay, we have here on the lateral surface what's called the prefrontal cortex. And there are two areas here, a dorsolateral prefrontal cortex, kind of shaded here in blue. So this is part of the middle frontal, part of the superior, even a little bit of the inferior frontal gyrus. So dorsolateral prefrontal cortex. And down here in green, mainly the inferior frontal gyrus, we have the ventrolateral prefrontal cortex. So there are several things that are known in terms of what this is responsible for. One is both the dorsal and ventrolateral prefrontal cortex are important for task setting and monitoring. And so you do a lot of this as medical students. You come up with a study plan. It could be for anything, planning your finances or a vacation. That would be task setting. Monitoring is then the process of, following through and checking how are you doing on that plan. Are you keeping up with your study schedule or so on? And so those are both activities here of the frontal lobe in this area. Okay, and also working memory is an important function of the dorsal and ventral prefrontal cortex. And so this is really juggling information as you synthesize it. Okay, so this is the function of a medical student, working memory. So actively retaining and manipulating information in the short term as you try to consolidate the information. Okay, that's working memory. So patients that have lesions in this part of the brain obviously have great difficulty doing that. And so interestingly, dominant hemisphere lesions, and I will explain hemisphere dominance here in a little bit. Usually the left hemisphere is the dominant hemisphere, okay? And so lesions here on the left hemisphere tend to more impair task setting. So that would be a more difficult task for someone with a dominant hemisphere lesion. Whereas the non-dominant hemisphere, again, usually the right hemisphere, tends to more impair monitoring. And so we have a number of ways, things we can do just at the bedside with the patient to determine, how their function is in this area. So here we're asking the patient just to draw alternating squares and triangles like this. Okay, well, if you have impaired monitoring, then you can't really check yourself as you do that. You kind of lose that. And so the patient here then starts to draw 2 triangles and 2 squares and now 3 triangles. So this would be an example of kind of impaired monitoring with a non-dominant hemisphere lesion affecting this area of the frontal lobe. Okay, if we do a section right down the midline of the brain to look at the medial surface of the frontal lobe, we want to find the central sulcus again, because that's our posterior boundary. And so here is the central sulcus. And again, I wouldn't expect you now to be able to know, why is it here rather than here. That's something we'll explain in the lab. But the area around the central sulcus is called the paracentral lobule. Okay? And so the area anterior to the central sulcus right here is again precentral gyrus. Okay, except now it's on the medial surface of the brain. So again, what is the precentral gyrus for? It's motor cortex. Okay, but I'll tell you in a little bit. It's motor cortex for the leg. So we have to go through the homunculus here in just a little bit. All right, so all of this then is frontal lobe going back to the central sulcus, which is right here. And so another structure here on the frontal lobe is right here as the cingulate gyrus. Okay, here's the cingulate gyrus here. It extends all the way forward. So this portion of the cingulate gyrus then is part of the frontal lobe. Okay, and the cingulate gyrus sits on a big white matter connection here called the corpus callosum. And the corpus callosum is a white matter pathway that connects the right and left hemisphere of the brain. Okay, so right on top of that is the cingulate gyrus. Now what we'll do in the lab here is I'll just have you look at the top of the brain at the interhemispheric fissure and reach in with your hands and pull the hemispheres apart. And if you look down in, then you will see this big pathway right here. So that is the corpus callosum. Okay, so then you need to remember what's the gyrus that sits right on top of the corpus callosum. It's the cingulate gyrus. Okay, so this is how we'll identify this here in the lab. Corpus callosum and then the cingulate gyrus here sitting right on top of it. Okay, let's make just a few clinically relevant things here about the medial portion of the frontal lobe. So here we have, again, the cingulate gyrus. And so shaded here in green is the anterior portion of the cingulate gyrus, so anterior cingulate cortex. And this area here is called the superior medial prefrontal cortex. Okay, and so these areas of the frontal lobe are important for what's called energizing. Okay, and I read this a few months ago, and I thought it was a really good description. What is energizing? It's getting the mental clutch out of the neutral position. So just the inertia, frequently in a really high intensity kind of a thing. So you've got one day to cover a lot of material to study for an examination. And just that ability to put everything else aside and really focus in a concentrated situation for a long period of time for an exam, that would be an example of energizing. Okay, so this area of the brain then is important for that kind of activity. And so if we have a lesion here, and I'll tell you later what sorts of things could damage this part of the brain, then we can have these three problems. They all start with A, if that helps you. The most severe form of it is called akinetic mutism. And these patients, I've just seen a few over the years, just lie in a hospital bed. They don't talk, they don't move, they don't interact. They have zero inertia to do anything. They can be confused with a patient in a coma. Okay, they're just not responding. Okay. More partial lesions that affect this area can cause abulia and apathy. Abulia means without joy, and patients that have lesions here, like a tumor, for example, may damage this area of the brain. Patients have a very flat affect. When you ask them what's going on, they speak with a very monotone voice. Yes, I have a brain tumor, but there's no melody to the voice. There's just not that emotional component to it. So they appear very apathetic. Okay, and so again, they've lost that energizing. It would be very hard for these patients to, be motivated to certainly to do something like to take a class or to go to work would be very difficult. Okay, so again, the two areas here are on the anterior cingulate cortex and superior medial prefrontal cortex. So on a real brain, here's the superior medial prefrontal cortex, and here is the cingulate gyrus right here. So it's the more anterior portion that is important for energizing. Okay, but all of this is frontal lobe, cingulate gyrus. And remember, the cingulate sits on this white matter pathway here, the corpus callosum. Now, if we turn the brain upside down and look at the undersurface of the brain, we have what's called the orbital frontal cortex. And so here we see our first cranial nerve. This is the olfactory nerve. So here's the olfactory bulb and tract. Okay, and we'll talk about sense of smell and how that works here in a little bit. And this medial portion, just medial to the olfactory bulb and tract, is a gyrus. It's called the gyrus rectus, which means straight gyrus, right there. Okay, and to say a little bit clinically about this, we divide the orbital frontal cortex into a medial portion here in yellow and a lateral portion here in pink. So this is all orbital frontal cortex. And this is a very important part of the brain for behavioral and emotional regulation. We have 2 hours where we go over kind of the neuropsychiatry, the neuroanatomy of all of that, but this is a very important area of the frontal lobe, the undersurface, and also for social cognition. And so patients that have lesions here, and Dr. Perot will tell you about a famous patient that had a lesion right here, they're often very disinhibited. They don't have that filter. And so when I see patients that have lesions here, they often come in, they're a little aggressive, they say things that are inappropriate. They may comment on the nurse, being cute in an inappropriate way. I was checking reflexes on a patient that had a lesion here in this area, and he kind of looked at me and said, "I'd like to hit you with that hammer." I was like, "Oof," I was a little aggressive there. And so that would be kind of what someone would appear with the lesion right here. Interestingly, these patients often have hyperphagia, especially for sweets. May just have a focus on M&Ms or something, and they just have a kind of an impulsive desire to focus on a certain suite, and they can have what's known as environmental dependency, which is really a need just to touch things. So I have a few patients with this, and they just need to put their hand on my shoulder or something like that. They just have to kind of explore their environment. And so it's an interesting kind of set of problems that patients have with lesions here. Now, if we look at the more tip, and again, these areas overlap, right? But the frontal pole is more the tip of the frontal lobe, which includes the medial and the lateral orbitofrontal cortex. But this more anterior portion here, called the frontal pole, is involved in what we call metacognitive processing. Okay, and this has to do with self-awareness and also the awareness of others, like the awareness of the emotions of others. And so patients that have lesions here classically will have impaired empathy. I've seen this quite a bit, where the spouse will usually say, you know, he's always just been the most caring person. But as a patient told me recently, she had breast cancer, and her husband just didn't seem to care. Okay, and he had a problem with this part of the frontal lobe. And so there was impaired empathy. So again, kind of that perception of the emotions of others is affected with a lesion there. And in a similar way, poor recognition of facial expression of others. So our brains are amazing, especially someone that you know. You can just, you know, the slightest eyebrow lift or something, you know what that means. And but if you have a lesion here of the frontal poles, you lose that kind of social cognition and awareness of the emotional experience of others. Okay, so again, all of this is orbital frontal cortex. The more medial portion, the more lateral portion, and the frontal poles here are kind of the tip of the frontal lobes. Okay, and I will upload here later today. I had a student go through and color all the different parts of the brain, and they're all labeled, and I think this will be helpful for you for the lab. So here's the olfactory bulb and tract, and in purple here is the gyrus rectus. And if you hover your cursor over the area, the name lights up and so on. So I'll have that uploaded here by the end of the day. Now, if we move back to the parietal lobe, now we have to go posterior to the central sulcus. Okay, and so again, here's our central sulcus. And so the gyrus that is just posterior to that is the post-central gyrus. And now we're in the parietal lobe. So all of this is parietal lobe here. Okay, so remember the precentral gyrus is for motor function. Okay, the post-central gyrus is for sensory function. So anything you feel in the arm or the leg or the face, that is perceived here in the post-central gyrus. Okay, there are a couple of other important gyri here in the parietal lobe, and we find those by following the Sylvian fissure all the way back to its termination, and there's a gyrus around that that is called the supramarginal gyrus, and posterior to that, a gyrus called the angular gyrus. So these are both a part of the parietal lobe, and there is some language function, especially understanding language, that occurs here in the supramarginal and angular gyrus. All right, if we look at the medial portion of the brain, this whole area of the parietal lobe here that is kind of posterior to the post-central gyrus is called the precuneus, and the precuneus of the parietal lobe extends all the way back here to the parietal occipital sulcus. Okay, so posterior to that we have the occipital lobe. Okay, so here's what I referred to earlier, the homunculus. And this looks at the motor and sensory strip, or the precentral and the postcentral gyrus. And so here's the precentral gyrus, and what you can see here is that the face and the lips occupy this lower portion of the precentral gyrus. Okay, and that makes sense because, I mean, just think of facial expression and the ability to speak, and not just to speak, but to have melody with your voice and to have it timed with your breathing and all of that. You have to have a lot of your brain dedicated to that. So that's why the face area is so large here on the precentral gyrus. And if we extend up here, we have the hand, And again, the hand representation is very large. The detailed things just with writing, typing, playing a musical instrument. We need a large area of the brain dedicated to that function. So this whole area, the precentral gyrus, is for the hand. And then the medial portion here is the leg. Okay, it's the same thing for the somatosensory strip. So the face, tongue and all of that for sensation is down here. The hand and the arm is up here. And then again, the leg is medial. All right, so again, here on the medial surface, we want to find the central sulcus. And in the lab tomorrow, I'll tell you how to find it, but I'll just tell you for now, here it is. There's the central sulcus. And so this whole area around it is the paracentral lobule. And so this then would be the precentral gyrus and the postcentral gyrus. And so again, what is the function here? Well, if we go back to this, you can see that in the medial portion, in the paracentral lobule, that would be the leg. So motor and sensory for the leg is in the medial portion of the brain. Okay, and I'll tell you later that bowel and bladder function is also controlled here by the paracentral lobule. Okay, so as a big picture, we've talked about the frontal lobe, superior, middle, inferior frontal gyrus, the precentral gyrus, the central sulcus, the postcentral gyrus, the precuneus. Okay, and hard to, now with it colored to point it out, but we've got a supramarginal and an angular gyrus here. Okay, so this is what we've covered so far. Now, remember I told you that to find the supramarginal gyrus, we follow the we follow the Sylvian fissure all the way back to its termination. Okay, so the area around that is the supramarginal gyrus, and then the angular gyrus is back here. And so this area of the brain is important for understanding language. Okay, remember Broca's area here on the inferior frontal gyrus is for speaking. This area then is for language reception. And it turns out actually that even though the supramarginal and angular gyrus are involved, the most important area for understanding language is here on the temporal lobe. Okay? This whole area of the brain here for understanding language is called Wernicke's area. Okay? And language function is usually on the left hemisphere or on the dominant hemisphere. So both for speaking and for understanding, it's a left hemisphere function. Okay. Most things that we will talk about in terms of anatomy is a function of both sides of the brain. Okay, but there are some functions that are just on one side, and language function is just on one side of the brain, mainly the left hemisphere. So if we look down here at the temporal lobe, again, the temporal lobe is going to be below the Sylvian fissure. So all of this is temporal lobe, and the temporal lobe consists of a superior, a middle, and an inferior temporal gyrus, just like we have a superior, middle, and inferior frontal gyri. Okay, and so language function, Wernicke's area, the most important part of that is here on the superior temporal gyrus, but it does extend out into the supramarginal and angular gyrus as well. So this is kind of a good representation here of Wernicke's area, superior temporal, and then out into the supramarginal and angular. Now, if we were to do some cutting, and we could just cut away a little of the frontal lobe, gyri here, and part of the temporal lobe here around the Sylvian fissure, and to look into the deeper areas here in the Sylvian fissure, it looks like this. Okay, and I'll tell you what these little gyri are here in a little bit. But for now, I just want to point out one. Number 4 here is called Heschel's gyrus. Okay, and actually what I'll have you do in the lab tomorrow is just take your finger and put it into that space, and your finger will be resting on Heschel's gyrus. Okay, and so Heschel's gyrus, notice it's right adjacent to Wernicke's area for understanding language. So it makes sense that Heschel's gyrus is primary auditory cortex, right? It makes sense that the auditory part of your brain is right adjacent to the part of your brain that interprets language, right? So we've got primary auditory cortex, or Heschel's gyrus, right here. So this is part of the superior temporal gyrus, is Heschel's gyrus right there. All right, if we turn the brain upside down, this whole undersurface right here of the brain is the temporal lobe. And so we have a couple of medial structures here on the temporal lobe. The most medial part of the temporal lobe is the uncus right here, and then just lateral to that is the parahippocampal gyrus. Almost all of the pictures that, or drawings that I'll be using in this course were done by medical students through the years, and so this medical student wanted to help you, I think, and wrote the stinkin' uncus. And so the uncus is primary olfactory cortex. So sense of smell goes back to the uncus. Okay, and I'll tell you in just a little bit here what the parahippocampal gyrus is involved in. But they're both part of the medial part of the temporal lobe. Okay, so again here in the colored picture, the yellow here would be the uncus, and then the lateral portion here would be the parahippocampal gyrus. Okay, an important clinical application of this is something that's known as uncal herniation. Okay, and this can occur from any mass lesion. We'll talk about subdural hematomas tomorrow. But any mass could be a tumor that causes increased pressure in the brain, and what that can cause is for the uncus to get pushed down. Okay, and that's called uncal herniation. And the significance of this is to realize that the uncus right here has a very close relationship with a cranial nerve, and this is cranial nerve 3 right here. Maybe the previous slide shows a little bit better. There's the uncus, and this is your third nerve. Okay, and so the classic exam finding of uncal herniation is that the patient has a third nerve palsy. Okay, I know you don't right now know what that looks like. We'll spend some time talking about it, but the third nerve is impaired in uncal herniation, and usually when the brain is herniated, the patient is usually not responsive. They're not awake and talking to you. They're usually in a coma. But the exam finding that would tell you why they're in a coma is that you find they have a third nerve palsy. Okay, so this anatomical relationship here of the uncus and the third nerve is really important. All right, moving back to the occipital lobe. Remember again, this is the parietal occipital sulcus right here. So anterior to that is the precuneus. And if we move back here, this is all occipital lobe. Most of the occipital lobe we see on the medial surface of the brain. Okay, and so the largest sulcus, often called a fissure, here in the middle of the occipital lobe is the calcarine sulcus. So above that we have the cuneus, and below that the lingula. Okay, and we call the cortex that's all around the calcarine sulcus the striate cortex, and this is primary visual cortex. Okay, so we see with the back of our brain. Okay, so primary visual cortex is this striate cortex here around the calcarine sulcus. Okay, so again, calcarine sulcus here, and we have the cuneus and the lingula on above and below that. Now, sometimes they're called lobes, but I think most people prefer not to use that terminology, are the insular and the limbic lobes, or sometimes called a system. And these are really parts of the other 4 lobes of the brain. So the insula is actually buried deep within the sylvian fissure. Okay, all of that cortex around the sylvian fissure we call the opercula. And if we were to do a dissection where we were to cut all of that opercula away around the sylvian fissure, well, it looks like there's a whole other brain in there. Okay, remember I told you 2/3 of the cortex is buried deep within the fissures and the sulci. And so there is the insular cortex. Okay, and it still amazes me how little we know about so much of what the brain does. So the insula, oftentimes we find out what the brain does by when a patient has a stroke or a lesion there, then they have a dysfunction of a certain area, and then we know, oh, that's what that was important for. So one thing we know is that the insula does have a role in cardiovascular regulation. If a patient has a stroke that involves the insula, interestingly, usually on the right hemisphere, they can have arrhythmias of the heart. But there are some other interesting things that with regards to taste, placebo effect seems to be a function of the insular cortex, interestingly. But not a lot is known, really, about the function of the insula. The limbic lobe or system, here we'll talk about it just a little bit. So just another nice picture here showing you the insular cortex. So 1, 2, and 3. This would all be part of the insula. And even if you just take your fingers and you sort of pry apart the Sylvian fissure and you look deep, you'll be able to see that. Okay, let's spend the next 5 minutes here talking a little bit about white matter. So we're only getting into 2 of our telencephalic structures here in this lecture. Right, there are several different types of white matter pathways. One are called projection pathways, and these travel long distances, either going from the brain out to the spinal cord or incoming information, like sensation from your arms and legs going up to the brain. So we use the term efferent if it's going out, afferent if it's coming in to the brain. So major highways is just the way to think of these. And so out near the cortex, most of this white matter we call corona radiata. So it's the white matter that's just underneath the cortex. And if we follow that deeper down, we get to an area called the internal capsule. And this has enormous clinical significance. So we'll spend quite a bit of time talking about the internal capsule. Okay, I wish I were talented enough to do a brain dissection like this. But here we can see nicely the cortex. Okay, and then these would all be projection fibers here. And notice that, so out here near the surface, it's the corona radiata. And then a large portion of this filters down into a very compact area called the internal capsule. Okay, so again, corona radiata out near the surface. As we go deeper down, it's the internal capsule. And as we get through the brainstem, I'll point out these white matter pathways as they continue through the brainstem. So we'll get to the naming then. Right, so let's just finish up today talking a little bit about the internal capsule. And this will be a bit overwhelming, but I just, again, want to reassure you that this we will cover so many times that this will eventually not be difficult for any of you to remember. The internal capsule is right here. It has a V-shaped structure. Okay, and you don't know any of the anatomy around it. We'll tell you that here at 11 o'clock this morning. But the internal capsule has an anterior limb, a genu means bend, and a posterior limb. Okay, and lesions here are very common. And so you have to know everything that is in the anterior limb, the genu, and the posterior limb. Okay, so here's a nice drawing that a student did for me a few years ago to illustrate pathways that are in the anterior limb, the genu, and the posterior limb. Okay, so let's just talk about this a little bit. Probably the pathway we will talk about more than any other in this course is called the cortical spinal tract, right here, the CST. And a lot of these names, named pathways, the name tells you what it does. It goes from the cortex to the spinal cord, cortical spinal tract. And so this is the pathway we will use mostly to illustrate movement. So if you have a lesion of the cortical spinal tract, the patient's going to have weakness. Okay, so that is in the posterior limb, and that's very important to remember. Also in the posterior limb are what are called the superior thalamic radiations. Okay, and this is a pathway that's going up to the brain, mainly to the postcentral gyrus, because it conveys sensation from your face, arm, and leg up to the postcentral gyrus. So the superior thalamic radiations are going up to the cortex. The cortical spinal tract is going down from the cortex down to the spinal cord. So they're going in different directions. Okay, but motor and sensory. Okay, and the last thing I'll tell you is there's only one pathway here at the genu, and that is called the cortical bulbar tract. Again, another pathway we'll talk about a lot. What is the bulb? The bulb is the brainstem. So this is how your cortex controls the brainstem. So all of the cranial nerves, a lot of other function of the brainstem. Of course, the cortex has to regulate and control everything. Okay, and it controls the brainstem right here via the cortical bulbar tract. All right, so let's stop there, and we'll pick up here in a couple of hours.